And thank you to Blake and Andrew Delbridge, who ran the surveys for this session for the problem mapping. And these are the 5 issues that we identified in the Hunter. What is the pathophysiology of plantar heel pain? Plausible differentials, including the sinister ones, when and how to image, understanding when and how to operate, and then understanding the suite of evidence-based treatment options. To guide us through that, we have our 4 local experts, Dr. Ross Cairns, sports and exercise medicine physician from Newcastle Sports Medicine, who is currently completing his PhD, and also the Socceroos doctor, Dr. Virgil Chan, fellowship-trained musculoskeletal radiologist, Dr. David Nicholson, fellowship-trained orthopaedic surgeon with a subspecialty interest in the foot and ankle, Mr. Blake Withers, who's a podiatrist and also a PhD candidate consulting out of Achieve Podiatry. And it is humbling to welcome our international expert, Mr. John Osborne, all the way from the sporting capital of Australia. John embodies everything we're trying to do at RIPN. He is a clinician and researcher. He's recently completed his PhD investigating plantar heel pain, and it's a real honour to welcome you, John. Thanks so much for coming, and we look forward to some of the insights that you'll share with us and to collaborating in the future. And if you'd please welcome John, he will start us with an introduction to plantar heel.
Yeah, we know. Thank you, Josh. It's a very humbling introduction. I actually want to start. I'll give you your outcomes. So we're going to look to try and define what plantar heel pain is. We're going to try and describe some of the risk factors and the associated factors of plantar heel pain. And then we're going to sort of try and outline some of that prognosis. So I'm going to give you the overview. Okay. Before we get into the overview, though, I want to take an opportunity perhaps to ask you all, to be comfortable with being uncomfortable. I get it. That's not plantar heel pain. But often, a researcher or somebody will get up here and will say, one scenario, but we'll get up here and we'll say, well, actually, more research needs to be done. And then you get a collective groan, either from me or from you. Then we get that other next scenario, where Ranjit comes into our clinic, and he has this expectation that you're going to provide something really profound that you learned tonight. And you have this expectation of us that we're going to give you something really profound. That means tomorrow your clinical practice has changed. The third scenario is that expectation. That expectation you have of yourselves and that the patient has of you that you're going to fix Ranjit tomorrow. I'm going to ask you guys to be comfortable with being uncomfortable. The reason researchers will say more research needs to be done is not because it dismisses your opinions or dismisses what's been done, but it opens the question for more answers to be made. The reason, Ranjit, and you expect this profound statement tonight is because you're really embracing what's going on. And I'm going to ask that perhaps you accept incremental change and not profound. And then the final thing is this expectation. Remove the expectation. It's really okay not to know. And if 10 years of dedicating my life to research has taught me anything, it's okay not to know something. So if I can just ask you guys to come with this idea of being happy or content with not knowing, that's a really good thing. Can I get some nods of heads or shakes of heads or something? Great, okay. So let's define what plantar heel pain is, okay? Plantar heel pain is that pain under the bottom of your heel when the person gets up in the morning and it's really tender and they can complain about it. And it always happens first steps after rest. And they'll always complain that it happens after prolonged periods of standing. Right? We all know this one, yes? Great, good. We love audience participation. Okay, so, but then if we look a little bit deeper, the condition's not entirely well understood. Okay? Your imaging features that are associated with plantar heel pain will show features that occur on the calcaneus. They'll show features perhaps within the intrinsic foot muscles, although there's no size differences in those with plantar heel pain and those without. There'll be features and changes in the plantar fat pad, but most frequently there will also be changes in the plantar fascia or the plantar aponeurosis itself, and it obtains that thickened aponeurosis. But it's not isolatory. Often you'll find in imaging studies, these things will all occur together. So that's why I want to use the expression plantar heel pain and not plantar fasciopathy, not plantar fasciosis, plantar heel pain, because it may not be that something is occurring in isolation, that's happening in conjunction with a number of other factors that are all happening around plantar heel. If we look at the prevalence of this, it's quite common. It's the most common thing I will see in clinical practice. Perhaps it's because I've been doing a PhD in it, but it's also just because it's a super common thing. It's about 10% of the population. Okay? If we look at prevalence still, so prevalence is a snapshot of the population, what's occurring within a population, okay? We can generally see that those over the age of 30, but I'm going to sort of tilt it more towards over 40, 45, it's more prevalent in that age group, okay? If we want to try and split that up now around sex, we can see it's also far more prevalent in women than in men. And it does continue for women, everything seems to always hit you guys, but it does seem to continue past that point of 50 years of age. The other big one's BMI. So it's really prevalent in those who are bigger. Okay? So the bigger you are, the more likely it is that you're going to experience plantar heel pain. So thinking about those big, broad factors, let's have a look at what the associated factors are. Well, we've covered these ones, age, sex, BMI. We can consider systemic factors, but there's not a huge amount of research that we can talk to around that. I could also ask you around range of motion, and you'd probably all say first MPJ, ankle, knee. I'm sure some people would also suggest that foot posture is a risk factor for plantar heel pain, footwear, hard surfaces, their occupation and activity, foot muscles, and we can talk to whether it's size, function, or strength. But what I want to try and highlight actually is the ones that once we take age, sex, and BMI into consideration and we do a much better quality study, and we're not just making a haphazard attempt at, well, what is happening at this snapshot of time? What's happening to the people who have plantar heel pain versus the people who don't have plantar heel pain? We're also going to say, well, we're going to match you all for age, sex, and BMI. And we're going to get a really concerted effort to try and get it as accurate as possible. We find that footwear and hard surfaces and occupation and activity seem to turn up far more frequently as associated factors in those with plantar heel pain. I'm using the expression associated because I can't say it's a risk factor. We don't know if it happened before, we don't know if it happened after. We just know that at this snapshot in time, these things are more prevalent in those who have with plantar heel pain. If I go back a step, a bit too trigger happy. If we think of just age and BMI, age is perhaps I don't know, well, I'm not sure I should have highlighted it, but anyway, BMI, footwear, hard surfaces, occupation, activity. Let's think about the pathogenesis of plantar heel pain. So there's this dual idea that plantar heel pain is a result of trauma to the heel, and that trauma then stimulates a healing response, which then gets us that thickening of the plantar fascia, or stimulates a response in the bone, or stimulates a response into the plantar fat pad. There's another theory around this idea of it being a tension-based relationship. So you've got this pull of the plantar fascia against the heel bone. Now, I don't have research to back this, but I question that one more than I question the trauma. I question that one more because this is all about impact. We've got more impact from larger people who are a bit older, standing on their feet for longer periods of time, with footwear that's not very well cushioned on hard surfaces, and their occupation activity is more extended periods of time on their feet. The tension idea really stimulates around this idea that the windlass mechanism is the way that we propel ourselves forward. Can I get a bit of a show of hands on the windlass mechanism so I can either briefly go through it or just accept understanding? 50-50 maybe. Okay, so the windlass mechanism is considered to be a passive mechanism. If I dorsiflex your toes, so dorsiflex those toes, that'll make the plantar fascia tighten, and then the recoil of that plantar fascia will allow us to propel forwards. So it's considered to be a passive mechanism driven by the plantar fascia. It's movements driven by muscles, not by a passive non-contractile tissue. If we look anatomically, the plantar fascia is probably more likely to be a housing for the muscles, which are generating the movement themselves. So while the windlass mechanism may be a true mechanism, it may not be driven by the plantar fascia. So this idea that it's a tension relationship may perhaps need more investigation, right? But it's unlikely in my perspective, unproven. The role of strength. Well, there's no size differences, there's no function differences. There may be some strength differences, but we can sort of cover that in this next idea. Is what about systemic factors and what about pain? So if we consider plantar heel pain to be the lower back pain of the foot or a non-specific lower back pain of the foot, there's a good recognition that perhaps pain has a big association in plantar heel pain. So those who have plantar heel pain have higher rates of kinesiophobia, have more depression, and have higher rates of anxiety. Doesn't necessarily mean it's a driver. It may be as a result because of the frustration of having to live with the condition. So how long are you going to suffer with this wonderful condition for? So there's a common held urban myth that if you've got it for 2 years, then it'll self-resolve. I've heard that a number of times. That's derived out of the paper from 1992. More recently, there was 174 participants put through a 15-year follow-up study where we found that the risk of plantar heel pain was likely to be at about 80% after 1 year, so you would still have it. You'd likely get to, at about 5 years, half the participants still had plantar heel pain. And then after 10 years, 45% of those people still had plantar heel pain. It's not a 2-year condition. More data on a similar data set shows that at 2 years, that point in time, 55% people still reported heel pain over that last 4 weeks. I think the bit that catches me the most is that 18% of people changed their assignments due to having heel pain. So 25% are reporting sick leave. People are perhaps not resolving plantar heel pain, but they're changing their activities to accommodate for it. So no wonder we have to try and deal with it when Ranjit comes into the clinic. So hopefully we'll understand the nomenclature I would like us to be using is plantar heel pain until we've been able to prove otherwise. It's going to be a common condition, so you're all going to see it. So you're all going to see those frustrations. Typically, it's age, sex, BMI, and hard surfaces that are the big one. For athletes, it's similar. They just don't have the BMI factors. There's one prognostic study on athletes, and it is time on feet, low cushion footwear, and so on and so forth. But I'm trying to keep this broad because it's not just athletes that suffer from it. The pathophysiology isn't well understood, and the mechanical systems from which we've determined this are really theoretical, and none of them have been proven heavily. And it is likely that this condition will persist, or otherwise people will choose alternative things to do.
Start with the scores, huh? It's a biased audience. Good evening, everyone. So first thing is, I'm not the Socceroos doctor. I have looked after the Socceroos, but I am involved still in that space. So, I just don't want you guys coming away from saying, he said. So my talk is just about my approach. I say my approach. There isn't an evidence base on how to approach plantar heel pain. So this is how I approach it, and just talking around that space. So for every single problem that I see in medicine, I think the devil is in the detail, and that detail comes from your history, not your examination as much. Now, I think you really need to take a very, very thorough history when you're talking about plantar heel pain, because we've got lots of conditions that are located in a very close proximity that can be hard to differentiate. And really, its pain behaviours might help guide where you're going to go with that sort of condition. So you take your history, and that should help stratify your list of differential diagnoses that you've all got in your head, or hopefully you will after tonight. And then your examination helps confirm or refuse those differentials that you have. And then we have further testing to use if required. And that makes, there's a mixture of blood tests if you're thinking about inflammatory arthropathies, there's urine tests with reactive conditions, but most commonly in this room, we're going to be thinking about imaging. And Virgil's going to talk about the pros and cons of different imaging, but from a very basic perspective, I think if you have a presentation you think is quite classic for plantar fasciopathy, or what we commonly call plantar heel pain, an X-ray can be really good to just rule out your nasties. You can see if there's a bone tumour, see if there's an unusual fracture. It's a really nice, safe, cheap, easy thing to access and to move forward with some treatment. But if you think there might be some red flags present, is it something of concern, patient's not responding as you expect, you get that gut feeling, then MRI is the next line. Because MRI can look at all the different tissues there, whereas ultrasound has limitations because it can't really look into the bone. And it's also user dependent. So if someone's reporting an expertise, it's really going to be highly dependent on the person actually doing the procedure. That's the slide I was talking to. So, but these are the old slides because nerve conduction studies was added to this. And the main reason that was added was to be aware that they're probably not that useful. In my clinical experience, that when I've seen people with what I think is neuropathic pain, nerve conduction studies are often normal. Not always, but often. So if they're positive, that might help guide you. But if you get a normal nerve conduction study, it doesn't mean that they don't have a compressive neuropathy present. When we're working through our history with our patients, 80% of heel pain is that classic plantar fasciopathy story. So we can have this real confirmation bias when we're talking to people. We just ask the simple questions of how it behaves. Does it fit what we think it should fit? So we can get onto the fun things like treatment and education. But we need to be careful because if we do that, we're going to miss all those other nitty-gritty diagnoses. So I would recommend that when you are doing your assessments, think outside of the box. Think about the things that don't fit plantar fascia-related pain. Ask the questions. Try and disprove the other potential differentials. Don't just prove the number one thing in your head. Otherwise, you're going to miss things. And that becomes more and more relevant the longer patients had this pain for, and they've seen more clinicians, and the diagnosis is less certain. So, every talk has a red flag section. There's not many red flags here. Same as everything. Fevers, bone tumours, you've got night pain, you need a high level of suspicion to pick these things up. Simple imaging will assess those. You do see lumbar nerve root pathologies.
You keep going. Wanted to go.
Yeah, you do see that lumbar nerve root pathologies causing this. I don't see it a lot, but I have seen it a couple of times. And CRPS, you think you'd be able to differentiate it, but I've definitely seen heel pain come in, particularly in a younger cohort that has been more of a reactive type of CRPS to another injury. We're not going to talk through this whole slide. This is more, people are going to have access to this later. I think it's really important to have an awareness of all the differentials that can cause heel pain. This isn't every single one, but these are the commonest differentials. And broadly, you're going to have your plantar fascia-related problems, whether it's a degenerative thought process with fasciopathy or an inflammatory systemic issue, or a fibromatosis, that there might be a history of Dupuytren's contracture. But the other conditions that I think that mimic this a lot are tendinopathies. The pain behaviour is very, very similar, and patients will often walk into your room and tell you you've got plantar fasciitis. And the story sort of matches, and then you examine them and you notice that actually their pain is nowhere near their plantar fascia, it's their tib post. So be very careful. And I normally get people to show me very early, like point where their pain is, because I think it helps guide your assessment quite early. The other big mimic for me is middle facet subtalar joint pain. It can really radiate into that area, and unless you palpate for it carefully, then it can be missed. And then the nature of the pain, you're going to get the history on can guide you whether you think there's a compressive neuropathy present. With examination, I think it's interesting seeing John's slides because I agree with those things. And the examination that I do predominantly isn't biomechanical. I will note someone's foot posture, but I don't really put any particular stock in whether they have a flat foot or a high arched foot. I'm really looking for obvious asymmetry and whether that is congenital or acquired and whether that's playing into this. But usually I'm not too fussed if they have symmetrical feet. I think function is useful to try and understand a little bit about how that patient experiences their pain, but there's a lot of limitations. We often talk about, it's a compressive pathology if they've got pain on their heels or a traction pathology if they're walking on their toes, but it might be still later. We know that with this. Pain comes on afterwards, and often you examine a patient, they're okay, and then 5 minutes later they go, oh, what did you do to me? So I think you have to be really wary of over-interpreting those sorts of functional assessments. But the palpation is really important. You're going to have your differentials. Feel carefully. As John mentioned, there's a lot of kinesiophobia. You see allodynia. You touch someone's foot anywhere near their pain, normally they jump. Now, if you start at their plantar fascia and they jump, that's not confirmatory of it being a plantar fascia origin problem. So I tend to move different areas and places where it should be completely pain-free to try and get a guide. And then I'll come back to where they've said ow before and I'll see if it's reproducible. And you want that reproducible pain on the day of assessment, but also on sequential visits to see it's consistent and matches what you think's happening. And then beyond palpation, you've got your special tests. Predominantly, we're looking at tarsal tunnel, Tinel's test following the nerve pathway along, and anything that might indicate there's a bone stress injury like a calcaneal squeeze test, or I don't think it's a real test. I call it the calcaneal thump test, right? Thump the calcaneum. It hurts if you've got a calcaneal stress fracture. Doesn't usually hurt with a fat pack intrusion if you don't do it too hard. So, look, in summary, you need to have a really good understanding of all the differentials that are present so you can work your way through them and then use your examination and test to try and confirm or refute your diagnosis, and understand all the limitations of your imaging tests. We're going to go on to treatment now, I believe.
Thank you. Well, thanks for the invite back to speak. So I always think that I've got a fairly interesting quick session, an easy session compared to everyone else anyway, because it's just imaging. So these are what we hope to sort of finish by the end of the session, where you can understand some indications, the utilities of the different imaging modalities, which Ross has covered quite well. So I can pretty much save that or speed through that. I tend to think that a plantar heel pain is really more of a clinical diagnosis. I don't really think that we get a lot of referrals when it's fairly clinically obvious to the treating person. And so my referrals usually come when I think there's some concerning unusual features that Ross has discussed, or that we're assuming that it's plantar heel pain and it's failing the usual treatments. So we're looking for something that might be a little bit strange or something a bit unusual. And the other thing that is always in the back of our minds is that you can always have abnormal imaging findings, but they may not be symptomatic. So the causes, I think Ross has discovered, has sort of discussed quite thoroughly. And here's just a quick list of what imaging modalities would be the best. So we're talking about X-ray being fairly quick, just to rule out a calcaneal stress fracture if it's apparent. Although sometimes if it's just bone stress injury and not a fracture, it might be a bit difficult. Looking for any causes of arthropathy and looking for a heel spur that everyone likes to look for, but we'll sort of discuss that a little bit later. how that really may not be that appropriate or that useful anyway. If you're looking for, in that area that was also discussed with everything that's in the heel, with the plantar heel pad, the bone and muscles, and obviously the plantar fascia, depending on what we are suspicious of, we can use the different modalities. So if it's a bone-based pathology that we're looking for, obviously MRI is going to be a lot better in depicting the bone as well as all the soft tissues, whereas ultrasound is mainly used for the soft tissues such as the plantar fascia and its associated tendons around like the Achilles, and looking for the bursas and looking for heel pad syndrome. So I think, if you were going to do one test that's most useful, you would do an MRI examination because that covers all your bone pathology, but also covers all your soft tissue pathologies like ligaments, obviously plantar fascia, but also the bone reaction to the plantar fascia, which we'll sort of show some examples of. Ultrasound is actually quite good. It's easy. It's, really quick, but it is a bit operator dependent, depending on how the experience of the sonographer, plus also a radiologist who's reading them. So with plain X-rays, like I said, looking for any arthropathy, stress fractures, and the heel spur. But we probably all have some idea that it's really common, and it's been sort of quoted up to even 55% of the population in different racial groups and different demographics have a heel spur, and it may or may not be a cause of pain. So it's not particularly a useful finding if you see one. So ultrasound examination is really easy. As I said, you can look at the plantar fascia in 2 or 3 minutes. And what we want to see basically is a plantar fascia on the left-hand side of the screen. It's a really nice, smooth outline. It's nice and bright or echogenic. You can see all the little fibers running through it on a really nice machine. And then on top of that, it's all the heel pad. So you're looking for any edema. So on the left-hand side, that's a longitudinal view of the heel of the plantar fascia at the calcaneus, and then on the right-hand side, it's just a transverse view. So really great. When you get abnormalities, you're looking for something like this. So you get this really quite thick-looking plantar fascia. It's hypoechoic. It's dark on the top, but it can be dark all the way through. You're losing the definition of the fibers and the fibrillary and the fibrillary appearance and the structure. You can see that, it implies basically that you've lost its normal fibrillous structure to the organized structure of the fibrils in the plantar fascia, and it gets really thick. The patient's usually quite sore over the area, so we can use the ultrasound probe, have a bit of a press around to see where things are. When it's pretty quite aggressive, if it's pretty quite bad, you can get that hyperemia, you put colour on it, and it looks really red, and patients love it because they go, oh yeah, this is my pain, I can see it. They go, the brighter it is, the more happy they get. Oh, this is exactly where my pain is, and then obviously then you look for tears, and you can also document any plantar fibromas as you go down the whole, and you can assess the whole plantar fascia from heel to toe. So then we'll move on to MRI. And this is just a quick plug to say that we've got I've put in a new upgrade. So now our MRI's been upgraded, and now we got basically deep learning AI in our system to basically help reduce scanning time, improve image quality. And the other thing that we've got, we call these ear coils. So they basically just like blankets. Instead of having, I'm not sure if anyone's had an MRI before. Most MRI scanners where you have to have coils put on to receive and receive the signal from the MRI. It's usually a very hard, rigid, fixed plastic brace that you put over the knee or the ankle. But now these are just like really soft blankets that fold around, and you can just wrap the body part, or like in the picture, you just put it over the patient. And these are actually even better signal. And the whole reason of the deep learning is basically to increase what we call signal to noise. And so as a result, in the olden days, we used to always try to just increase signal. So you had 3T and you just like scan for a long time to get more and more signal out of the tissues. And so that would help with the signal to noise ratio. The higher the ratio, obviously the better and the nicer the pictures are. now with this AI, we just try to reduce noise. And so in the end, we still get higher signal to noise ratio, but we're not trying to just pump it through, we're not just using high, magnet strength. We can just now do it with a 1.5T and get pretty decent pictures, or pretty nice pictures, I think. So going back just to anatomy on MR, lots of structures. This is just something I've taken out from one of the anatomy books online that I use quite often. Basically, it's an imaging atlas, and it just shows you basically all the important structures on the sagittal view of the hind foot and the plantar heel area. You can see that everything's been labelled, lots of different structures that can be a cause of pain. And then we've got a coronal view, again, multiple tendons, ligaments, etc., and nerves that can be a cause of problems. So the plantar fascia on MRI, which is one of the important structures that we're looking at for plantar heel pain, I usually use the term plantar fasciosis. And again, the plantar fascia should be nice and black and well defined on MRI imaging. When it gets thick and it loses signal in the sense that it becomes a bit more grey rather than black, that indicates some degeneration, change, or fasciosis, fasciopathy. With the most left side picture, you've got just a thickened plantar fascia. It's a bit intermediate signal. You can see that the adjacent muscle just deep to that has got some signal change in it too, which is what we're talking about. That is not just the plantar fascia in isolation. That's the problem. So there's lots of structures all been affected, or, not sure if it's all affected or the cause of pain or the result of pain. I'm not really sure which way it is, but you can see quite a lot of structures. And then the middle picture basically shows that you then also may have some bone marrow edema at the insertion, and that's at the calcaneal insertion, to a stage where on the right, you've got a thick plantar fascia. It's even brighter or even whiter in signal. You've got this big fluid cleft at the calcaneus where the spur is, to indicate a partial thickness, knee full thickness tear of the plantar fascia in that spot. And then in this instance too, you've got lots of other changes. You've got changes in the muscle, you've got changes in edema and brightness in the heel pad and the soft tissue of the heel pad. So again, it's the whole area as opposed to just the plantar fascia. Now, just whilst we're doing MRIs to help with our patients, obviously not everything with heel pain is the plantar fascia or plantar fasciitis or plantar fasciosis. So obviously we're using imaging to exclude other diagnoses that we've discussed before, such as Achilles tendinopathy or Achilles tendinosis. This patient's got a tear on the left-hand side. You're looking at a stress fracture in the middle. So lots of bone marrow edema in the calcaneus with an oblique sort of hyperintense or black line across the top, which is the stress fracture line. And then we've got someone who've got on the right-hand side some posterior ankle impingement that can give you some sort of, pain in the foot. But like as Ross says, they're sometimes not very specific about where the location is. And that one's a big striated process with a bit of bone marrow edema. Oops. And then the other thing that we can look for with MRI is looking for nerve impingement. So we've got a good look at the tarsal tunnel in the image plane. On the left-hand side, there's lots of ganglion cysts giving you a tarsal tunnel syndrome. And then the other thing that we can look for is Baxter's neuropathy. Now, the nerve can be quite hard to see itself because it's tiny, but we're looking for any sort of denervation in the muscle that's supplied by the nerve, such as the ADM. And if you can see edema in that, then we can sort of infer or suspect that there's some neuropathy or some sort of compression. And for people just as Baxter's nerve, that's just the first branch of the lateral plantar nerve as demonstrated on the pictorials. Sometimes people call it the inferior calcaneal nerve. Not something that we can look at on ultrasound. Sometimes we can see it, but you need someone who's pretty experienced to try to look for a very small nerve. But sometimes worth looking at, and sometimes worth considering that it might be neuropathy involved with the pain. So, summary is that I think that plantar heel pain is predominantly a clinical diagnosis. It can help with the clinical assessment. It can help exclude other causes that you might worry about, especially red flags. And also a lot of the imaging findings, like everything else, we need to sort of take into account the clinical context to make sure it fits with the clinical context. Thank you.
Welcome back. So this thing I could get to treatment, which I think is a bit more interesting. I'm going to try and understand the treatment options that are available to us, so you can perhaps choose an appropriate treatment pathway, and then appreciate what the evidence and the advice is around some of the treatments that exist. Again, I'm going big picture on you all. Blake can get nice and specific. But if we look at what treatments are available and want to go compare them all, the available evidence doesn't necessarily support one of these being any better than any other. Okay, so if we're going to look at them all and stick them all on a graph, everything's marginally effective. That perhaps speaks to some of the stuff that's already been sort of spoken about by Ross and Virgil, where perhaps we don't necessarily know which treatment for which pathology. Perhaps we don't know which treatment for which person. And perhaps we don't necessarily know what even the pathogenesis is to begin with. But it's not necessarily that one of these is always going to be necessarily better than any other at a single point in time. The next thing that comes out of this study of comparison of treatment options suggests that cortisone injections alone or in combination with exercise and shockwave appears to be far more likely. So it's more likely that if we collectively put our treatments together, that we're more likely to get some form of positive result. Third statement out of this is that control treatments, which include over-the-counter stuff, generally show less beneficial effects than other treatments for people with plantar heel pain. So control treatments aren't necessarily effective, so we want to provide some form of intervention. But again, that wonderful statement that shows that we need some high-quality randomised control trials to try and get us move forward. If we keep on looking big picture, there are 3 clinical guidelines that have been presented. So one is by surgeons, Journal of Foot and Ankle Surgery. One is by predominantly physiotherapists, Journal of Sports and Orthopaedic Physiotherapy. And then one is a collective of a couple of podiatrists, a couple of physios from the UK and from Australia. The podiatrists and the physios reckon that we should do taping, stretching, education, shockwave, then go into custom foot orthoses and then do an injection. The surgeons reckon we should start with orthoses, then go to taping, stretching, injection, shockwave, and surprise, surprise, have surgery at the end. The physios reckon we should do stretching, reckon we should do manual therapy, night splints, dry needling, strengthening, no mention of foot orthoses, surprise, surprise, right? So like everybody's on their little pathway. Okay, and no one's going to agree on anything. What they all do agree to is that we need to treat each patient individually. Okay? So, unlike these 3, I don't think it's worth throwing something out. Okay? Particularly given that stretching keeps showing up, and I've just heard him whisper, right? But there's no difference in ankle range of motion in those with plantar heel pain compared to those without. There's no difference in knee range of motion, hip range of motion, or first NPJ range of motion in those with plantar heel pain compared to those without. So are you addressing a deficit, or are you addressing a movement change and a movement fear? Right? Comfortable being uncomfortable. So, given that we need to treat each patient individually, I'm going to flick it over to Blake to try and cover that.
Why was the slide there? I think it's right.
Blake can get his feet out.
Randomly, the next slide.
I can speak like a sports doctor.
Yes.
Yeah. I love these mics. It feels so professional. All right. So, skip through these. Now, easily, plantar heel pain is the most common thing that I see in practice. At least, I think the survey that starts like 5 times a week. I think at a minimum it would be at least 3-4 times a day, like every day, 6 years. It wears you out. Now, there's lots of things that we can do, but as John said, there's a lot of things that seem to outcompare
anything else. So this is the framework that we use in clinical practice, and this is what I explain to patients. I have a little diagram for them to understand it and see. And I see a lot of people when they're in pain, and this obviously works for tendons, for heel pain, for a lot of things. And initially we're just trying to calm something down. It's painful, it's sore, it's affecting their quality of life. They can't go for a run, they can't play with their kids, they're trying to lose weight and they can't walk. And we're trying to tell them what they need to do. You need to do exercise, you need to do this, you need to do that. But sometimes we just need to get them out of this phase. It's painful. If you're running and it's sore and you're walking and it's sore, doing more of that probably isn't going to be that helpful. And maybe doing more exercise or a really dedicated 20, 30-minute exercise per day is probably not going to be that helpful. Once we get them out of this phase, and we can use these therapies, which we're going to talk about, we get them into the capacity phase. And that's building back to what they want to do, their meaningful activity. I'm a big believer in strength training, but I'm not a big believer in it has to be that specific. If somebody wants to run, what's more specific than running? Start with a couple of minutes and slowly build up. If they want to get into the gym, why don't we start with what they can do and slowly build from there? And we use their meaningful activity because people come to see us because they are in pain and this heel pain is stopping them from what they want to be able to do. And then we get to this minimum effective dose. Now, not to be critical of the physios here, but when we talk around foot orthoses and footwear and taping, it's a common belief that if you get a pair of foot orthotics, you have to get out of those things as soon as you can. They're killing you. You've got to get out of them. And you have a look at something like this. There's a bit of an arch, there's a bit of cushion. I really encourage you guys to come and have a look. They're pretty awesome, cost effective. We're going to speak how effective they are, but something like this can really help someone. And we look at this capacity phase, this minimum effective dose phase, and we work out for someone, what do they need to maintain their quality of life? For some people, it is a cushion shoe. I wear barefoot shoes to work. Would I run in them? Of course not. Really, really uncomfortable. But for a nurse who spends 40 hours on her feet, who's had heel pain for 2 years, is it really that harmful that they still wear their foot orthoses? Or they do need to do their rehab every day, or they do wear a big cushion shoe like a Ghost Max. So we need to kind of question this. What do we need to do? A lot of people don't need these devices, and a lot of people don't need to continue with shockwave. They don't need to continue with a lot of the treatments that we do. But we really need to question this when we talk about these devices. So can I have a hands up? Has anyone seen this before? Yeah, very good. This is my favourite slide ever. I wish it was based in humans, but it's not. It's an algorithm. So when people come to see me, I usually explain a couple of things, what's going on, help them make sense of their pain. But I use this to help them understand the load, because I have two options in clinical practice with foot orthoses and shoes and things like that. I can reduce the number of cycles that someone takes. If someone has heel pain, and we call a cycle a step, I can reduce how many steps they take. We're all really good at that. Load modification, do a little bit less walking, or I can reduce the force per cycle. And we can make such a meaningful difference to someone's pain if we look at both of these, how many steps they take and the stress per cycle. So if I say to someone, you're doing 10,000 steps per day, we can bring that down to 8,000. That's probably logically going to help their pain. But what if I can reduce the force per those 8,000 steps? I should be able to, again, get some relief. So when we're working with people, this is what I'm trying to do initially, is modify that stress per cycle. And this is where these types of therapies really come in. I promise I'm going to talk about something more on foot orthosis. So we see where people sit, and there are plenty of times in clinical practice, I will put someone with heel pain in a cam walker, in a moon boot. They're in so much pain, they really can't walk. Foot orthoses, shoes, taping, probably not going to help them that much. And I work with people a lot of the time to get them from here, where they need a lot of protection. If someone has a high-risk stress fracture, we know they need to be in a boot and crutches. Wheelchair, not so much. But we want to try and get them down to here, no restrictions. That's the goal of working with someone, trying to understand how do we move your pain down this scale. Now, I work with a lot of barefoot people. I do online consults, and people consult with me to get from here to here. And usually it's just a greater exposure. It's not too specific. But again, I'm trying to get them to this point. But some people, as I said before, with plantar heel pain, they may live here. They may have this simple soft device. They may have a big cushion shoe. Ideally, they're not going to have a cam walker or a Ritchie brace, but they may need these things into the future. So, show of hands, who thinks custom foot orthoses are better than prefabricated foot orthoses? 2 minutes. Is that 2 or 20? It's the wrong question to ask, because it's so hard in the research to be able to get one group and apply that to everyone. And it's the wrong question when we think of applying these biomechanical theories. We're trying to work out more so for someone, what aggravates them. If someone has plantar heel pain and they're really painful when they walk, this is a custom device custom device scanned to a generic foot. That's going to be really uncomfortable to someone to land on. Whereas something like this, relatively soft, relatively cushioned, with a cushioned shoe and some heel raisers, we can take up some of that pressure away. Compared to if someone has a plantar fascia tear, what do we know is going to aggravate a plantar fascia tear? It's going to be that tensile load as they push off. 5 minutes or just waving? That's going to be really aggravating when they push off. So when I have something like this, is that really going to help someone with a plantar fascia tear who's really sore when they push off? Of course it's not. But something like this might, a carbon plate. I mean, might use that in the short term. They don't have to go into a boot, they have to go into crutches. So understanding the loads gives us a better idea. And I truly think in clinical practice, and again, it is just my opinion, that this is so much better to understand when it comes to anything. If we talk about the patellofemoral pain, if someone has knee pain, what do we know is going to aggravate someone with knee pain? More knee flexion. And we tell them to reduce that. If we know someone with heel pain is sore when they land on the heel, bit of debate with compressive versus tensile, I believe it, but maybe I'll say that out in silence, that if someone really comes down on the heel, something really soft is going to be better for them. Now, I always get the question, how much should foot orthoses help? And this is an awesome paper. This device here is this without a cover on. This is just a prefabricated device that comes ready-made that you can stock in clinic, and it's one of these without the cover on top. When these people walk in these devices, the shoe is the control, how much pressure goes through the heel, a 29% reduction, almost 1/3 of less pressure through the heel. That is, I mean, I need to see you guys smiling. This is incredible. I think it's groundbreaking. 29%. Something like this, they can buy online, or they can just sell that in the clinic amongst everything else that we do. Now, we can't say that each percent reduction is going to lead to, each percent reduction in pressure is going to lead to a reduction in pain. However, if someone has pain when they compress the heel, I can reduce the pressure by 29% with no adverse consequences, maybe other than money, that's a really meaningful difference for someone. So, when do we use custom? As we can see, usually when we need more contouring. Now, if you're a podiatrist, this debate goes on all the time. John and I met we went for lunch, spoke for 5 minutes, then we got straight into this debate, as all podiatrists do. But it's the wrong question. When we're thinking, what do we need? These prefabricated devices, they're made for the generic foot. Sometimes we do need contouring, the device to match the arch, maybe we need more force application. And there is research to say there are differences between custom and prefabricated. Whether it's meaningful for heel pain is another question. So sometimes we do need that. The nurse, I said before, who spends 40 hours on her feet, probably going to wear through this pretty quickly. And if she says, listen, I just feel more comfortable in it, what's the worst case scenario for me getting a custom? There's a cost associated, of course, but it is going to be more durable. So this taping, I hope this plays. This taping I've spent, this taping has taken me years to perfect. So I tape around the base, basket weave, and then I tape up through the arch. Now, I will get patients to film this, or I'll get a family member to film this, and I will sell them a roll of tape for $14 and get them to self-tape. We see low-dye tape very, very clearly helps people, and you see them in clinical practice. You tape them, they get up, they put pressure through their heel, and it's really, really reduced. It's so simple and easy. They don't have any skin irritation. I can ask them to do something like that on the first day that I see them, or a family member can do it with a device like this, with a cushioned shoe, and we can start to really get some meaningful change for people. Now, Shockwave, I really don't know about Shockwave. It seems to work in clinical practice. It really, I see some amazing outcomes. I see people where we Shockwave their heel, we get them to stand up, and they put pressure through their heel, and they do not have any pain anymore. I have no idea why that is the case. We don't really understand how it works. In this study here, they asked 25 experts, should you include Shockwave in your treatment? And you have a look at the percentage. It's pretty high. 100% of people say it should be included. Now, the research doesn't suggest that. It's varied, and it doesn't say it's any better than doing a sham Shockwave. But in this study, guess what also really helped? So they all perform about the same. We really love exercise here as physios, of course, and we do as well as podiatrists. But what was just as effective as anything else that you can do is giving them a custom foot ortho and just giving them some education. It's just as good as anything else, which really challenges our bias. And there was a study that came out recently 4 days ago looking at Shockwave compared to good quality physiotherapy for proximal hamstring, and they were the same. So there's something in it, I just don't really know why, because some studies show, like this one, that it's no better than sham, but in here we see it's recommended, sometimes it shows an effect. And we talk about what's the pros and the cons. Some people charge a whole lot probably too much in my experience and from what I've heard. It can be painful during, of course, but you don't have to start at that high dose. There are some harmful bleeds, breaking up scar tissue, all that type of thing. But you can get some buy-in. You can change someone's pain. What's really important for someone coming to see you, developing that therapeutic relationship, I'm going to trust you if you can change my pain. So I can do shockwave, I can take them, prefabricated device with some healers and a cushioned shoe, and I still get to do the lovely education and the exercise and everything else. So it can really help. Now, has anyone seen this shoe before? The UFO. Yeah, this shoe, if this shoe goes to mass market, I'm out of practice. This shoe is unbelievable for heel pain. You make this device and you do a good quality shoe like this and you tape them up and you think this is going to be comfortable. They come in and go, yeah, what you made is pretty good, but the UFO is just as good. So we need to think again, what are we trying to do? Goal-based prescription, what is aggravating? The features of the shoe need to try and address that load, and then comfort, financial access. So a nice cushion shoe, again, there's plenty of them out there. It's going to be really helpful in combination with this. One critique of other health professionals I think podiatry is really good at, I see patients all the time that have these shoes at home and they're not wearing them. Like, yeah, I wear these when I go for my walk, but when I get home, I'm just barefoot. Again, that's load per cycle that I can change. And it's awesome because they say, oh, I feel better in my thongs. I feel painful around the house. Have you thought about wearing those thongs around the house? Oh, far out. That's way better. You come back and go, great, it'll be $100. So, shoes. Again, people love to wear these shoes. They're flat. What do we know it's flat? There's less surface area between the ground and the foot. It's going to be painful when they land. We're going to have maybe increased tensile strain on the ankle. The plantar flexors work hard. That's going to load the foot. Something like this, the Ghost Max 2, and this is the recommendations I'll give to patients. I do not care at all what the shoe is. It can be Hoka, Nike, whatever, as long as it has roughly about a 30 mil strap at the back, and we're on an 8 mil drop. That's great. I can put some heel raisers in, I can put a soft sole in there, or they can just use that. And we look at the loading. It is so easy to implement with no adverse effects really associated other than wear your shoe more, maybe some self-taping, we can put some things in the shoe, and we can rotate them between. But it's so easy to try and, again, help them with their pain. I can't say that doing this is going to get them better than anything else that they do, but it is clear when they put these on and you ask them, do you feel better in shoes? People feel better when they do not have as much load through their heel. So that's all I'm trying to do. That's all we're trying to aim to do. John, this one.
This is a Delphi study that I conducted a couple of years ago. Can you hear me back? Yeah, great. We ended up coming out with 3 different programs you can provide for exercise for those who plan to heal pain. But it's not tried and tested. I'm honest, after spending a lot of time on the PhD and looking at strengthening exercise to plan to heal pain, I'm probably not likely to issue it. I'm probably more likely to do a weight system. Provide them with a footwear and address that risk, that associated factor, and to try and address some of those cushioning factors. There's something about clinician experience, which I'm pretty sure what we're doing.
Ross's slide.
Cortisone injections, where are we at here? We got natural history on this side. So it's talking around that natural history and the idea of trying to utilise cortisone injection. I'm fortunate, our branch has got endorsed it as well, so I can do cortisone injections. And typically you're looking at, on average, for a cortisone injection was about 3 months. If you compare cortisone to PRP, I appreciate that there's some clinical differences about N=1. But the long-term outcomes are reasonably similar when you compare cortisone to PRP. The question that I raise is, well, what about BMI? It seems it's an associated factor. And what about pain? So if you're a GP in this room or you're a sports physician, why aren't we utilising our dietitians? Why aren't we utilising our psychologists to also help us manage this condition? Because I have a hunch that if I took a three-arm trial, you guys can go and lose weight and do whatever exercise you choose to do. You guys can have foot faces and cool shoes. I can give you guys some strengthening exercises. My hunch is this group will get that. Right? The other stuff, a bit Voltaire, it's a bit of a dance to do. I do slowly get better, and I think it's important. I think it absolutely addresses some of the issues. But we're probably dealing with a bigger societal problem, which is that of what weight. Right? It's a bold statement to make. I appreciate that. I might have said that. I'm sorry for that. But it's absolutely involved with 3 carries less than this. All those? Maybe. Right.
Why skip that?
All right. A couple of the other slides I have were just speaking a little bit to our language around treatment. And one of them is we use first line. We all talk about first line as a way to solidify what we want to say and say this is the best treatment. And I think we have to be really careful about using that terminology with our patient groups in this space, because first line implies this is definitely the thing we should be doing. This is the best treatment. Everything else beyond that is not the best treatment. But we don't have any data to back that up. And it also varies from patient to patient. I mean, is first line the most effective? Is it the most cost effective? And is that from an individual perspective where private health insurance plays a role in their decision if they can afford the orthotic or not? Is it if they're funded to have an injection? Or is it when they get back to work better? There's so many different aspects to that. So I think when we're talking here, we need to be open to all different treatment modalities, and that what's best for the patient isn't necessarily the least invasive. It's individualized. And just because I can't make an orthotic doesn't mean I won't offer it to a patient. And just because someone can't do an injection, it doesn't mean you shouldn't discuss the potential outcomes from an injection. And I think when you have that wider holistic approach with your patients, they get more buy-in to what you are trying to sell. Essentially, you're trying to get them to have different treatment options. But if you don't tell them about these things and what you've already offered hasn't worked, then you look a little bit dodgy when you start saying, well, there is this other thing we can do. But if you have that conversation early and be open about the expected treatment outcomes, I think you get a lot of buy-in, and you say, this works for this person, doesn't work for this person, and they're willing to try it. So I think it's a really good approach to patients. The other part is that we all have very different perspectives when we see patients, depending on what timeline we see patients. So Dave and myself are going to see a group of patients that are basically operating outside of our evidence base. We don't have good quality, large studies to say that there are people that have 3 years of plantar fascia pain that then respond to this or that. Doesn't exist. So we are in the Wild West trying to work it all out. And natural history is against us. So if they've not got better by the time they've seen us, very unlikely to say to a patient, give it 6 months, see how you are, because it's unlikely to be satisfactory. Whereas yourselves, if you're a primary care provider, you have that little bit of natural history on your side, which is great, but you have to be careful, because that also means that what you do may not be the thing that's fixing them. You're going to be open to that, you're supporting them on that pathway, but is it you that's fixed them? Is it natural history? Now, John's data suggests that it is us fixing them, apparently. So if they're all getting 10, 15 years of pain, or 1 in 2 are, then perhaps the treatments we use are effective. But, it just adds to that whole unknown. So when it comes to injections, there isn't a treatment that is considered to be the best treatment. And trying to choose who to inject is tricky. There isn't one part of seeing a patient that says, you definitely need this injection. And what I think is really helpful in choosing who needs an injection is about their preconceived ideas for treatment. Because if we can't stratify patients based on data, we need to at least have very strong therapeutic relationships, because we know that's helpful. And if someone's coming to see me, they don't want to be told, get an orthotic necessarily, or they've probably done that pathway. If they haven't explored that, then it'll be a conversation. But the sort of patient you see, they are going to have certain things they're seeking. And although you need to have this open discussion with all the options, you also need to explore what they might be wanting as well, because I think that will help your long-term buy-in and outcomes. In my hands, I tend to not offer an injection until I've made a couple of months of attempt at treating them with simple measures. So a lot of things have been spoken about. I like to have footwear modifications, oofs by the side of the bed and in-house, and a cushion shoe with a rocker bottom sole, I think, is just really great. I think load management is really really crucial. If they keep overloading it, I think it's going to keep being sore. I don't actually feel I see a huge number of obese patients or overweight patients in my clinic. It's interesting that data. It doesn't match with what I see. But it's a sports clinic, so maybe they don't want to come to a sports clinic. But I think it's a very difficult thing to change in the short term as well. It's very hard. And I prescribe intrinsic foot exercises, which have no data that I'm aware of. It's just, something I feel helps. Podcasts I've listened to, and it gives people something to do and be in control of their condition, which again is helpful. And if they don't get any better after a couple of months, then I think that's the time to start looking at doing an injection. And I would say a lot of people don't end up needing the injection after that. Often that chat and reassurance is helpful. In terms of what to inject or what treatments we've got, there's a few things, and you could argue they're all, black medicine. They're all potions that don't have great proof for their use. But the commonest ones would be cortisone and PRP. Obviously, there are other things available, but they're harder to access. This whole evening is about trying to be evidence-based. And one of the things that really stands out to me is that we don't really know how to measure outcomes in plantar fasciopathy or plantar heel pain. So we're saying this works, that doesn't work. Well, if we don't know how to measure it and it's not being validated, we can't actually say that. So we might actually be using successful treatments, we're just not measuring it properly, which I think is hard to get your head around given how much data is out there, but it speaks to Josh's opening sentence that 85% of studies have critical, fatal flaws, and 100% of plantar fascia research has those flaws. So it doesn't really help us. And they're essentially glorified VAS scales, most of the research. And that's about your worst pain, which isn't very useful when you're looking at a whole person and their function. And even the papers that do say there's helpful things like stretching, if you go and look at the original paper for stretching, they cherry pick one element of a foot and ankle score and it says that your first step pain in the morning is better. But there was no difference in the foot and ankle score. But from that, everyone forever has said stretching is the treatment for plantar fascia pain. So you've got to be really careful. And we can't tell you what to do in this because if the data isn't there, it's not solid data, then it doesn't inform us. But let's say it was good data. Even amongst that, there's discrepancy between outcomes with guided and unguided injections. There's debate over whether the injection should be perifascial or intrafascial. All the data for cortisone that I've seen doesn't include betamethasone, which is the commonest medicine that I see used in Australia. And is that what you'd normally use, Virgil? Yes. So is it the same? Is it not? And then PRP means the age-old debate for PRP. The people that believe in it say, my PRP is a better PRP, better prepared, different injections, put in a different site. So it's really hard to actually trust any of the data. But the one thing that I think is good is that there are thousands of people that have been studied with these injections. And there's, in all the papers that I saw and all the systematic reviews, there's no significant adverse effect. So there's not been any ruptures reported. There's not been infections. It's safe. So injection is a safe option. As John's already touched on, the outcomes are quite broad, but cortisone in general is effective for the first 1 to 3 months. Platelet-rich plasma tends to work a little bit later and may last a bit longer. Botox and dextrose injections have some sort of promising research, but it's all really small numbers. It hasn't been backed up with reproduced studies. So I think it's really hard to support their use as any sort of close to first-line therapy, first-line injection. But there's some emerging evidence on radiofrequency ablation, where I think this comes in when you've got your really refractory patient and you tried everything and you're thinking, this patient might need to see Dave. But there's this other option if you really don't want surgery. And the data suggested outcomes are similar to, say, fascial release surgery, and it's better if it's combined with cortisone as well. So it's a potential treatment option in refractory patients. That's Virgil's slide. Just perifascial, yeah. Okay. All right. So just I think all treatment options should be offered to all patients, not just your own field. Data isn't really supporting us to go down any one particular avenue or not, and just give that honest advice to your patients and have them involved with that decision-making pathway. And I think you'll have more success than sort of telling them this is what we need to do. And it's 6 for.
Is it really? Jeez. That's terrible. Do you want the microphone on for recording, or?
We can pick you up from the front, but if you wander around, it won't grab it.
I can just stay here if you like. So, g'day everyone. Thanks very much for having me here. I've got to say, we've got it easy. These guys have got it tough. They deal with all the hard bits. If their treatment doesn't work, they come to us. We do an operation, fix them, go home, all done. It works every time, every single time. Okay, we know that's not true, but it's a nice thought, but it's not true. So we're just going to go through the indications for surgical referral. It's obviously a last resort. Think about some of the options that we have and then understand the evidence and outcomes for surgery, which you won't be surprised are not that great, but are probably to some extent getting better. So in regards to surgery, we have had over the years generally low quality evidence, a lot of cohort and case series. Inclusion criteria, I think, has been a big issue. You look through papers, not just for surgery, but for non-operative treatments as well. Some look at patients who've had pain for 3 months, 9 months, 12 months. Like to me, that's a big thing. Like we were always taught you don't treat anyone surgically until they've had pain for 12 months. We know from John's data that even that's probably not long enough to wait. But I just don't think there's much benefit looking at surgical treatment in patients who haven't had either a significant length of time with pain or have been through essentially all the other treatment options. The papers have different variabilities in technique. Do you release the entire plantar fascia? Do you release the medial third? Do you release 2/3? Do you operate at different points in the calf? All that kind of thing. So that's very hard to compare across papers as well. Thankfully, there's a low complication rate. I spoke about the waiting for 12 to 18 months. There's biomechanical factors and anatomic structures, which, as we've learnt, are not clearly understood. We really don't know what the pain generator is in plantar heel pain. That may be coming clearer to some extent from our point of view. But the good news is most people don't require surgery. And this is one thing that comes out of the surgical papers. This is a really common problem. It's estimated that in the US every year, at least 1 million people are treated for plantar heel pain, which if you divide, down to our population, we're talking, 100,000, 150,000 people a year potentially having plantar heel pain. I'd actually be surprised if it was that low. I think it's probably more than that, but but then it becomes very important to work out who you're going to operate on. So just in terms of the surgical options, the sort of classic surgical option was the plantar fascia release, which I did lots of as a registrar, as an open procedure, often combined with a heel spur ostectomy. I'm not sure where those numbers came from. But anyway, keeps it interesting. You get the classic patient who comes in and you say, what does it feel like? And they say, oh, doctor, I've got spur pain, because they've seen the spur on their x-ray and they think it's the spur. And when I was training, we would finish an operating list with, a plantar fascia release and knock off the spur. No one ever got better, but certainly not from the spur. But you realize, you look at this when you're a registrar and you sort of think this doesn't really work, So anyway, so plantar fascia release, you can do it open, you can do it endoscopically, but then you think, why would it work? I mean, why is a surgical release of the plantar fascia any better than someone just rupturing their plantar fascia? Like, you end up with the same result. Why does it work? And that other issue is how much you release. There's debate about if you release the whole thing, do you get instability of the joints of the foot and things like that. And most of the papers that looked at this make these great statements like it has generally good outcomes. So fantastic evidence. Knocking off the heel spur, we can basically say there's no evidence of additional benefit of including that in your surgery. And then the really interesting thing, which is giving me hope for the future, is the gastrocnemius fascia release. And it can be done in a number of ways. It can be done open and endoscopic. This is just the picture down below is an endoscopic one where you, at whatever level they're doing it, you look at the gastrocnemius fascia and you divide it and you see the muscle underneath to show you you've got a release. But then it can be done distal in the calf. It can be done proximal in the calf. There's some biomechanical basis for doing it more proximally in the calf in terms of weakness and loss of function of the calf musculature. And we're starting to get some higher level evidence. And some of that evidence shows that patients will get earlier pain relief with a gastrocnemius release than with a plantar fascia release. So in the early 2000s, people started to think about this, and they started to notice a correlation between isolated gastrocnemius tightness and plantar heel pain. And there's been a couple of systematic reviews which were done in 2021 and 2022, so quite recent. They basically looked at the same papers. One of the reviews had 7 papers that met their criteria, one had 6. Reading this is something that, once again, makes me think about the numbers. You think about the numbers of people who have this condition, they came down to 6 or 7 papers that looked at about 140 patients, 128 patients in one paper and not many more in the other. So, this is a hugely common problem, but the evidence base we have is based on a very small number of patients. And then there's another paper, not a great paper, but just looking at degree of heel pain or severity of heel pain, correlating it to gastric tightness, and there was some correlation. So when we look at isolated gastrocnemius tightness, most people are probably aware of this test. This is what we rely on. Basically, the gastrocnemius crosses the knee and the ankle. So with the knee extended, it's at full stretch. And if you can't dorsiflex, or you can basically, when someone has a tight gastrocnemius, you can dorsiflex the ankle more with the knee flexed than you can with the knee extended. And a lot of the papers that are talking about gastrocnemius tightness, isolated gastrocnemius tightness, being important in plantar heel pain, based on a difference between the flexed knee and the extended knee. Not necessarily saying that if you can't dorsiflex to plantar with an extended knee, you've got a tight gastrocnemius. It's a comparison between the flexed and the bent knee. There's another bit of my slide that might be my next slide. There we go. I'm all over this. Okay, so this is why theoretically the gastrocnemius tightness contributes to plantar heel pain. So essentially the knee is in extension from the end of swing phase until just before the beginning of toe off, sort of through that the end of stance phase. And if you can't dorsiflex your ankle, your foot's flat on the ground. If you can't bring your tibia forward over your foot and it remains here, theoretically it increases the tension in the plantar fascia. John may debate this about the lack of the windlass mechanism. I don't think this necessarily relies on the windlass mechanism. I agree with John that the plantar fascia is a static structure. It has no elastic recoil that has a propulsive effect. It's purely driven by the muscles. But this is essentially the theory of why isolated gastrocnemius tightness possibly, probably, maybe contributes to some extent to plantar heel pain. Stick with me, guys. I'm going somewhere. Okay, so this is 2 papers which have essentially changed my practice to some extent. They come out of Norway, and we have Ante here with us tonight, who's a surgeon from Norway. He visited us a couple of years ago and talked to me about this treatment for plantar heel pain. And then I sort of looked around at changing my practice and have largely changed my practice based on these papers. So there's some things that excite me about these papers, right, which don't happen in orthopaedics a lot. It's a randomised controlled trial. That's a good start, looking at what we've got from previous papers, right? they looked at patients with pain lasting more than a year, which is what we're always taught, you know. But once again, the thing that I found funny is that plantar heel, they say in the paper, and we've got to look at papers critically, you know, we're all taught to critically read and looking at papers. Plantar heel pain is a common disorder, but they had 40 patients. So it's not a huge population. You know, you sort of think everyone's got plantar fascia. I've got a perimenopausal wife at home who's got plantar fascia. She's like, why can't you fix me? You know, like, it's just, it's a nightmare. She's going to hate me for saying that, but anyway. So they did it for 1 year, and then this was the other thing that excited me. They then came back and looked at the same group of patients 6 years later. So this is pretty good science, and for orthopaedics, this is really good science. You know, to follow up. They followed up 33 of the patients, about a 80% follow-up rate, which is good. Small numbers, but pretty good follow-up rate. 7 patients did cross over from the non-surgical treatment to the surgical treatment, which probably affected the results to some extent. The American Orthopaedic Foot and Ankle Society score improved significantly in the operative group, but not in the non-operative group. And VAS pain, for what it was worth, was significantly better in the operative group. Interestingly, no difference in dorsiflexion between the two groups. At 1 year, there was an improvement in dorsiflexion in the surgical group. It wasn't sustained through the 6-year review, but once again confirmed a low complication rate. So just in terms of the proximal medial gastrocnemius fascia release, which I didn't actually point out, that changed my practice. I went from doing a mid-substance or a mid-calf fascia release to a medial gastroc fascia release. It's day surgery, immediate full weight bearing, no boot. They start immediate ankle range of motion exercises, which are essentially stretches with the knee and extension. I let them jog as soon as they can after 6 weeks. Full recovery, 3 to 6 months, probably best case scenario, a bit longer than that, and only a 10% reduction in calf power, essentially. So, okay, thank you very much.
All right, thanks so much, team. We're going to quick 5-point play. Plantar heel pain will not burn out. History is where the money's at. Image if red flags or non-responder, and treatment, see outside your own biases, match the treatment to the patient, and I think most importantly, try to give the patient control of their pain. We're going to have a quick break, hydrate, and then we're going to come back and have a quick panel discussion. Cool. Oh, yeah.